Good afternoon, everyone. Welcome to this webinar on why and how civil society can contribute to the 5th reporting round of the WHO Global Code of Practice on the international recruitment of health personnel, hereafter called the Code for brevity's sake. Today's webinar is intended as a technical webinar in the sense that we would like to show you the nuts and bolts of how to engage with the code reporting process that has recently started. It will be video recorded, as you will have noticed when you entered the room. And my colleague Pearl will eventually make the recording available to you. We have divided our program into two distinct blocks. The second block is where Agya Mahat from the World Health Organization will give us some background information on the code, its principles and objectives, and on the code reporting process in particular, and why it is important to engage in reporting, not just for member states governments, but also for non-state actors. So that is you and me and everyone in this room, I think. And after that, Thomas Schwartz from Medicus Mundi International will guide us very practically through the 2024 reporting instrument for the non-state actors. And this is going to give you an idea of what to expect and how to provide what sort of information when you decide to actually submit a report. But to get you all geared up for this second block and convince you that there are really reasons for you why we'd like you to engage in the reporting process on behalf of your organization, we've included a first block with speakers who, based on their own experience, will present their unique perspectives on what is happening in their context relating to health and care worker recruitment, mobility, and migration, and who will share with us from their viewpoint why they feel it is important that everyone shares such perspectives through the code's reporting process. So you can consider this first block sort of a motivational intervention, and I hope that you will indeed draw some inspiration and motivation from it. For your information, we intend to take questions at the end of this webinar. You can just raise your hand then, and Pearl, my colleague who is behind the scenes taking care of the technical stuff for this webinar, Pearl will then unmute you so that you can ask your question at the end of the webinar, if there is still time. Okay? Then we have a couple of housekeeping rules that you can see in the chat, how to raise questions. We've covered that, and that the recording is being, that the webinar is being recorded. So I think we're set to go. Let's dive into that first block to set the scene for this webinar. We have 3 speakers for you in this first block. You will have seen their names in the programs. They are Itai Rusike from Zimbabwe, Martin Leschhorn from Switzerland, and Gillian Roque from the Philippines. And I will introduce them in a bit more detail when it's their turn to speak. So let's go to our first speaker, and that is Itai Rusike. Itai is a public health activist from Zimbabwe. He wears many different hats. He's executive director of the Zimbabwean Community Working Group on Health. He's a board member of Medicus Mundi International. He's a chairperson for the Zimbabwean chapter of the People's Health Movement, and many, many more. And I'm stopping here because it would eat too much of our valuable time. Itai, we are very, very happy to have you here. If you can unmute yourself and please share some information on your context and how you see the importance of engaging with the code reporting process. And may I remind you, we've agreed before that you have about 6 to 7 minutes for your intervention. The floor is yours, Itai, please.
Yes, thank you very much, and greetings from Harare in Zimbabwe. And I'm really happy, to be part of this panel, especially given the current challenges that Zimbabwe is also facing in terms of the outflow of health personnel to the region and also to the rich countries. So Zimbabwe, just like the rest of the countries in our region, has been facing, a public health challenge in terms of the outflow of health workers, health personnel, nurses, doctors, pharmacists, have left and have continued to leave the country to destinations like the United Kingdom, New Zealand, Australia. And what we are also seeing now is that health professionals are now also leaving to, the non-traditional, destinations, countries where they previously were not moving to. And we are seeing, active recruitment of Zimbabweans occurring despite the existence of regional and international codes on, recruitment. Such movement of health workers almost, collapsed our health delivery system. A very good example is like what happened last year in the capital city of Harare. 9 of our clinics had to close because there were no health workers. And the impact in terms of access to healthcare services was huge. Unfortunately, we may also stand to lose, some of the gains that the country had achieved over the years in the area of, maternal and child health, HIV, malaria, and so forth. We also saw an increase in terms of even, home deliveries because communities had no access to health, facilities. If you look at Zimbabwe, we are still using the staff establishment of 1983. In 1983, our population was only about 7.5 million, and it has since doubled to almost about 15 million. But in terms of the numbers of health workers, we are still using the same establishment of 1983, despite the increase in population, despite the increase, in disease burden. So as a result, the few health workers who have remained are also completely overwhelmed. And you see, burnouts, and you see regular, strike actions by the nurses, doctors, and this trend is very common, across the region. Whether it's in Zimbabwe, whether it's in Kenya, you'd find doctors and nurses are always going on strike, mainly because sometimes they lack the tools of the trade, and their remuneration is also not, adequate. But I think what we should also appreciate are the measures that are also being, put in place to try and retain, the health professionals. For example, in Zimbabwe, health professionals now fall under the Health Service Commission. Previously, all the civil servants were under the Public Service Commission. So the government, in trying to, limit the outflow of the health workers and improve their conditions of service, they have now come up with a Health Service Commission, which is more or less autonomous in terms of coming up with the, incentives, conditions of service for the health workers. Similarly, we have also seen the government coming up with some innovations. In Zimbabwe, we now have a cadre that is called a primary care nurse. And the government is trying to limit both this primary care nurse compared to the, a registered nurse, only trained for about 6 months. And the government thinks that this cadre may not be very attractive, to the countries that, are recruiting, our nurses. But I think what is also important to highlight is the issue of domestic health financing. Because the challenge that we see, in the health delivery services in terms of human resources for health is the issue of the physical space. you would realize that, in Zimbabwe, the government is caught up, between, a rock and a hard surface, in the sense that, one, there's a serious shortage of health personnel, but secondly, we also still have, nurses who are, unemployed because of lack of the physical space. So it's also important that we address and deal with the issue of domestic health financing. Most importantly, meeting the regional and the international, targets and commitments. I'm sure you're aware that most of the African countries committed to the Abuja Declaration in 2001 to allocate at least 15% of their total budget, to the health sector. Unfortunately, you then realize that very few African countries have been able to meet the 15%, allocation, to the health sector. So as a result, there's always a challenge in terms of making sure that there are adequate resources, to compensate the health workers. But as civil society working in partnership, with the health worker organizations, we have also been advocating for the government to come up with other, non-cash incentives, because we realize that from the budget, the money is never adequate. So the government of Zimbabwe has also come up with some measures in terms of the non-cash incentives to try and attract and retain, the health professionals. We also
I would like to round off, Itai, to give the other speakers as well some time. One concluding sentence?
At community level, we also have a very important cadre, community health workers. And these also play a very important role because they've got a direct interface, with the community. They live in the community, they speak the local language. So as a result, we have seen also the government increasing the numbers of these community health workers to make sure that we also, address the issue of healthcare services, especially at community level.
That was one long concluding sentence, but a very important one. I understand why this is important to add, Itai. And it's very encouraging to see that, to hear from you that there have been measures taken by the government to increase retention and decrease the outflow, actually. So yeah, that's important information on how the code is implemented, basically. So thank you, Itai, for your well thought out points. Now let's turn to Martin Leschhorn. Martin is the director of Medicus Mundi Switzerland, and he serves as president for Medicus Mundi International as well. He's based in Basel, Switzerland, and has been engaged in the code and its topics before it was even adopted in 2010. So Martin, a warm welcome. We are happy that you're here to share some of your insights and that we can tap into your institutional knowledge, so to speak. So please, over to you. And can I also ask you to be mindful of the time? Martin, floor is yours. Thank you.
Yeah. Thank you very much, Corinne, for this kind introduction. Dear colleagues, hello everyone. Since the World Health Assembly has adopted the code, Medicus Mundi Switzerland is advocating for the implementation of the WHO code here in Switzerland. We have built up a civil society coalition consisting of different stakeholders, including medical associations, trade unions, people from organizations from the sector of the international cooperation and the international health cooperation as well, and as well academic institutions. The coalition has aimed to sensitize Swiss decision makers in politics and in the healthcare sector on the WHO code. In 2012, we've published a manifesto called Do Not Solve the Health Workforce Shortage at the Expense of the Poorest. The manifesto, I think, met with a broad public response. It had a significant impact on the debate in that the recruitment of healthcare staff abroad has not been problematized here in Switzerland in terms of migration politics, but was instead addressed as a question of global solidarity and Switzerland's international responsibility. This was very important for us. So these are some years ago. We are still contacted by medias about when it's when there are debates on the shortage of health personnel here in Switzerland and how to solve it. But let's have a look where we are now today. After 12 years of good words, a pandemic that has marginalized health workers in Switzerland and worldwide, and ultimately forced many of them out of the healthcare sector, it is becoming increasingly clear that the recruitment of foreign healthcare staff by healthcare providers here in Switzerland is becoming ever more shameless. Last year, for example, the cantonal hospital in Aargau, so a public hospital, organized a casting in Rome to recruit nurses. And recently, the cantonal hospital in the Basel Landschaft, another canton, as well public sector, made negative headlines when it hired 7 nurses from the Philippines. This has been done the first time here in Switzerland. So there is an urgency here in Switzerland. And for this reason, the coalition led by the Swiss nursing associations and us, Medicus Mundi Switzerland, we have decided to publish an urgent appeal in the coming weeks, probably even next Thursday, 23rd May, calling on Swiss stakeholders in the healthcare system to adhere to the code and invest in a high quality working environment in the healthcare sector. Based on the fact that Swiss voters, so the Swiss population or Swiss voters here in Switzerland have approved 2 years ago an addition to the Swiss constitution that strengthens nursing, our appeal calls, and here I cite, that based on this success, and that this success that we have this now in the constitution gives Switzerland a special legitimation. We call in this new call that, and here I cite, Switzerland should act as an international pioneer for the implementation of the WHO code and work within the WHO to make the code more binding. We are still far away from where we want to have the Swiss government. So just to end and to wrap up, the MMS I want to talk about MMS contribution to the WHO reporting. MMS has also been coordinating Switzerland's civil society reporting here for some years now. It is also invited by the lead organization or administration here in Switzerland, the Federal Office of Public Health, so this is our Ministry of Health basically, to submit its report as an annex of the official Swiss report. And why is this so important for us? The contribution to the WHO reporting is central, and we will do it this year again. There are 4 main points. First, it is essential for securing information and documenting the implementation of the code here by Swiss stakeholders, so mainly the healthcare sector. Secondly, it emphasizes the relevance of the code as a framework for health workforce planning and for ensuring a high quality working environment here in Switzerland. Third, it links Swiss health policy with Switzerland's international cooperation, as well with the Swiss foreign health policy from a civil society perspective, a perspective that asks for more coherence from the government. And finally, the report is an excellent instrument for us here in Switzerland for our policy dialogue with political decision makers and as well for our advocacy work. So thank you, Corinne.
Fantastic, Martin. I mean, this is a really clear call and very also from a high income country perspective, something that resonates with the situation in the Netherlands, for example, where I am from. denouncing the government for this excessive recruitment, but cheering them on in being leaders on the correct implementation of the code and using the code as an advocacy instrument. Yeah, thank you so much.
Absolutely.
That's a
Thank you.
very, that's a very insightful remark. Yeah, observation. Thank you. Then we turn to Gillian Rock, last but not least. Another person whose credentials are too many to list here. Gillian has nearly 2 decades of experience in union organizing and policy advocacy, and in campaigns related to workers' rights, migration, and gender equality. She has actively engaged in various international and intergovernmental conferences and processes, such as the Global Compacts for Migration and the International Labour Organization. And today she is here in her capacity as a representative of the Philippines Public Services Labor Independent Confederation, or PSLink, affiliated with PSI, the Public Services International. Gillian, if you can unmute yourself, thank you so much for sacrificing your evening, basically, and being here with us today. And we'd love to hear your perspective on this. Please, the floor is yours.
Hello, everyone. Good evening from the Philippines. International health worker migration has continued to grow through the years, and our country, the Philippines, is right in the middle of it, consistently serving as a major country of origin for nurses, doctors, and other health workers. And while health worker migration is increasing, our health workers in the country continue to suffer from very poor working conditions. Many continue to be underpaid and overworked. Many nurses are paid below living wages. A lot of health workers are in precarious jobs without security of tenure and adequate social protection. There are still areas in the country, especially the poorest, most disadvantaged areas, without access to doctors and nurses. Trade unions in the Philippines are still fighting for the release of promised mandated allowances for health workers who served at the height of the COVID pandemic. Our hospitals and health facilities continue to grapple with high attrition rates. And it's our community health workers, almost all of them women, bearing much of the burden to implement universal healthcare, but are not even recognized as workers and are therefore working without pay and social protection. So while we deploy nurses and other health workers to other countries by the thousands every year, our health system continues to be beset by problems, including lack of decent jobs, unsafe staffing ratios, and maldistribution of health workers. Migrant health workers also face various risks and challenges while working abroad, from loneliness and isolation to depression to various labor rights violations, including illegal recruitment, contract violations, substandard pay and accommodation, lack of integration support. Many are charged excessive recruitment fees and other related costs. Many are unable to exercise their fundamental right to freedom of association and collective bargaining. Some face discrimination, racism, and xenophobia. Some experience different forms of violence and harassment at work, including gender-based violence and harassment. A lot of our migrant Filipino nurses and health workers also got infected and died of COVID-19 and related complications during the pandemic. And while migrant health and care workers, majority of whom are women, provide much needed essential care for their foreign employers and families in the countries of destination, nobody is left to care for their own families and children left behind. Labor migration, driven by reliance on remittances, driven by aggressive international recruitment practices for profit at the expense of workers' rights, at the expense of right to health of the people, can never be sustainable or just. Labor migration governance that treats our health workers as mere commodities to be traded, where equal treatment is not guaranteed, where core labor standards are not respected, where social costs and impacts on public health systems are not taken into account, and where the ability of governments to deliver the right to health of the people are jeopardized, can never be just and sustainable. We in PSLink and PSI believe in people over profit. We believe that labor migration should not undermine decent work and public health systems, and that migration should be done out of choice, not necessity. And this can only be done by ensuring fair and ethical recruitment practices, by ensuring a rights-based approach to health labor migration, by addressing structural drivers of migration, including existing decent work deficits in the health and care sectors, unpaid care work, and gender inequalities, as well as by ensuring all governments prioritize public spending for quality health services and health workforce sustainability. We need to ensure that we recognize and protect the right to decent work of all health workers, whether they stay in their countries of origin, whether they migrate for work abroad, whether they permanently migrate in their countries of destination or return back to their countries of origin. We need to ensure that health labor migration is undertaken in line with existing UN ILO norms and other relevant tools, including the World Health Organization Global Code of Practice on the international recruitment of health personnel. Health labor migration is growing increasingly complex. Learning from our experiences during the COVID pandemic, given increasing health and care needs, social costs of migration, global health workforce shortages, and the impacts of disasters and climate change, having adequate information on health labor migration can help our governments make informed decisions and implement rights-based effective measures. And this is why participating in the stakeholder reporting on the implementation of the WHO Global Code of Practice has become even more relevant today. We can help our governments adhere to the code and improve our legal and institutional frameworks, including our bilateral labor migration agreements. By engaging in the stakeholder reporting, we can further push the role of governments in fulfilling its role in strengthening health systems and creating sustainable health workforces, improving attraction, education, training, and retention strategies in the health and care sectors, ensuring migrant health workers are accorded equal treatment and have decent work and social protection. Lastly, the WHO Global Code of Practice was realized through the active lobbying and advocacy of PSI and other civil society groups. Now that it's there, we as trade unions and civil society need to make use of it, actively engage in the process, and by contributing to the reporting process, we will also be able to improve implementation and also strengthen the code itself. Thank you for listening.
Fantastic, Jillian. Yeah, that's a very strong call on on everybody here actually to engage in the reporting and use it indeed as an advocacy instrument. And you're taking certainly a 360 degrees angle on the whole discussion, how the rights of the people in the Philippines, the right to health is compromised, how labor rights are compromised in the Philippines, but also of the migrant health workers who go abroad. Those are very strong points that need to be brought forward in the code reporting. Thank you so much. A very forceful intervention. Thank you. So we've heard from three different perspectives, and I can feel the energy building already when it comes to code reporting. The relevance of engaging in the code reporting is certainly evident for me, and I hope for you too. So let's dive straight into the second block of this webinar, and let me point out to the audience that questions will be taken at the end of the webinar if there is still time. You can put your, you can write your questions down, but you will give it a chance to raise your hand at the end of the webinar, and you will be unmuted by Pearl. Not at this moment, at the end of the webinar, if there is still time. Let's move to the second block. How to contribute to the fifth round of code reporting. And let's dive into the first presentation with Agya Mahat, the technical officer in the Health Workforce Department at the World Health Organization's headquarters in Geneva. Agya, may I invite you to start your presentation? And if...
Oh, okay.
Yes, there you are. The floor is going to be yours.
Okay, just 1 second.
Sure. Yes.
Okay, namaste.
Namaste.
I will just quickly go through the context and how to report on the code, especially since the COVID-19 pandemic. This issue of international reliance on health workforce by high-income countries has received increased media attention all over the world. And this is why it's important for WHO. And I would like to draw your attention to the two maps here. The first map is on the density of disease burden all over the world. So the darker blue the color, the more disease burden there is. And the darker reds and the darker reds are the one where the disease burden is less. The second map, which seems to be just the opposite color in most countries, is the density of health workers. And here the maximum density is countries in darkest blue, and the least density is countries in red and darkest red. So from the data available with WHO, Africa has only 4% of the global stock of the health workers. That's doctors, nurses, midwives, despite having the largest burden of disease. And then there are 10 high-income countries that have a lesser, much less disease burden. That's less than 10% of the global disease burden, but more than almost 25% of the global stock of doctors, nurses, and midwives. And the same 10 high-income countries also host a majority of migrant doctors and nurses. And based on the data available with us, about 3 million health workers worldwide is a migrant. And these numbers are actually an underestimate for two reasons. One is not all countries give us the disaggregated data on the foreign the share of foreign health workers in their countries. And second, this data also excludes the number of health workers from low and middle income countries who migrate to high income countries but do not work in the regulated health professions. So there may be lots of health workers working as care workers. So this data does not capture that. The reason for this increase, and this has happened since the beginning of this century, has been the increasing burden, the increasing aging population in high-income countries and the increasing burden of chronic illnesses. So there is increased need for health workers, but this has not come together with increasing production capacity of health workers in the high-income countries. Much of it is stagnant or it has not kept pace. Since COVID, now the existing health workers are now opting for part-time work or switching careers or taking early retirement. So that has also created an additional shortage. And the easy way to meet that shortage has been through international recruitment. Low and middle income countries, on the other hand, have increased production in the past couple of decades, but employment opportunities are very limited and working conditions often do not meet expectations of the health workers. And COVID has decreased the financial space for health, as mentioned by our colleagues earlier, which means that it's not just difficult to employ more health workers, it's also difficult for governments to retain the ones that they already have, and especially when the global market is available for these health workers to go and work. So this has implications on health equity, and which is why this issue is important for us. And if we learned anything from COVID, it is that no country is an island. So weaker health systems anywhere in the world can have the potential to turn into a pandemic and shut down the global economy and pose a threat to global health security. Now, there are several international instruments that govern international migration. The WHO Global Code of Practice is the only one that directly links health worker migration with investment in health system strengthening. It was adopted in 2010 after a 6-year negotiation process. And as Gillian mentioned earlier, civil society organizations and non-state actors played an important role in driving this agenda forward, advocating for the issue, keeping pressure on the WHO to adopt this code, And then since its adoption, they have also played a role in continuous engagement with the code on advocacy for implementation and participated in the reporting process as well. The main objectives of the code are to establish ethical recruitment principles and practices and to advance international cooperation. Now, there are 10 articles in the code, mainly on ethical principles of international recruitment of health workers, realizing the right to health of populations, as well as the right of individual health workers to mobility based on individual country laws, health system sustainability, reducing reliance on international health workers and trying to meet domestic requirements through domestic health resources. It promotes technical and financial assistance to developing countries and promotes bilateral agreements so that the needs of both countries be met through this arrangement. It promotes circular migration and transparency in health workforce data. And although the primary audience of this code is member states, the member states are advised to work very closely with other stakeholders to implement the code, and all stakeholders, that is the health workers themselves, the recruiters, employers, health professional organizations, unions, and all government or non-government organizations that work in health systems and health workforce are responsible for implementing the code. Even though this is voluntary, it has a very robust implementation monitoring and review mechanisms. Since its adoption in 2010, we have had 4 rounds of reporting already and 2 rounds of review. The 5th round of reporting was launched last month, and the 3rd round of review will start next month. And based on the review, there is a possibility for the code to be updated if required to meet its objective, or there may be recommendations on how to strengthen the implementation of the code. This has been the trend of reporting from member states. So there has been a big increase compared to the first round, but quite stagnated since the 3rd and 4th rounds. And the reporting from non-state actors was introduced only in the 2nd round of reporting. And then there was a big spike. We got lots of reports on the 3rd round, and again, some stagnation on the 4th round on the number of reports received, although the diversity of organizations participating in the reporting has increased. And last time in the 4th round, for the first time, we also engaged with private recruitment agencies, considering their increasing role in international recruitment. And we had a participation of almost 188 recruitment agencies. Most of this was largely thanks to the government of the United Kingdom, because all of their recruiters in the NHS employers ethical recruitment lists had participated.
Agya,
So,
can I ask you to wrap up within
yes.
a minute or so? Yeah, thank
Yes.
you.
So the last advisory group gave us recommendations that we have been working on. And just to draw your attention to the health workforce support and safeguards list, the reason I have this here is to clarify that the code does not intend to ban international recruitment from anywhere. It advises countries to invest in countries that face the most health workforce vulnerabilities. Now we have some activities related to the code this year and next year, but the main focus would be on the 5th round of reporting and the 3rd review. The reporting instrument for non-state actors includes that for independent stakeholders and private recruitment agencies, which Thomas will talk about next on what is the instrument for independent stakeholders. The due date is 31st of July. And the report from this will go to the World Health Assembly next year. and the individual reports submitted by member states and the independent stakeholders will both be made publicly available after that. And for more information, please check our website or please write to us. Thank you.
Yeah, fantastic. Perhaps one of my colleagues could, I think it's there in the chat already, the last link that you shared, but this is very important information and very relevant. If I'm not mistaken, we are going to share your PowerPoint presentation in a PDF format after the webinar on our website. And of course, people will be able to look at the recording again after this and let all the information sink in a little bit, because it's a lot of information, but it was very, it gives a good context and background. Then, of course, our next speaker, that will be Thomas Schwartz, Executive Secretary of the Medicus Mundi International Network and of the Geneva Global Health Hub, and a passionate global health advocate and our long-standing and trusted network manager, facilitator, knows everything about the code, if you ask me. And you will guide us through the independent stakeholder reporting instrument. The floor is yours, Thomas.
Yes, thanks. And it's really nice to be again here on the webinar on the code after many other opportunities that I have had for really discussing this instrument and also debating its effectiveness and relevance. I think we need to be critical also about those two aspects from a civil society point of view and match what is written in the outline of the code with our own experiences. How do we experience as health workers, as people engaged in health systems, what's wrong, and then see if this instrument is really a way of addressing some of the crises that we see around us or ourselves as health personnel on the move. So I already put a link to this independent stakeholders reporting instrument in the chat. And I will just go on that website and lead you there. I could kindly invite Itai, Martin, Julian, Gideon, and Agya not to be too far away, because we might even have a bit of a discussion about how this instrument fits with where you are. So there's a website where you just have the title and an overview of what's going on. And then the main thing is that here you can link, you have a link to a PDF file. I already opened that one and it looks like this. It's just a long PDF file which has the title, Independent Stakeholders Reporting Instrument, which provides a bit of a background information. And then here in yellow, the link to the form where you can provide input. So I don't click there, but what you will get there is the same that is afterwards documented also further down in this document, with indication that the deadline is 31st of July. It then has a bit of a background on what is the code, and then it asks you to provide some information about who you are and why do you think that you should report, also how you are engaged in this field. And then it has lots of questions. And I have downloaded this PDF file just to, and I open it again with some annotations. So I worked a bit remotely, but it's the same file that you have seen. So it's just that you see a bit what I highlight. One of the things that you see is, first in yellow, you don't need to be an expert, or you don't need to be have information in all those many questions that are asked. It's sufficient if you have one strong story to tell, one strong experience, one strong figure that you can share with the WHO Secretariat and the team that tells the story of what's wrong, or maybe how the code could be used or whatever. Second one, here in the title or in the introduction, it refers mainly to countries. And I have just heard from Agya and that you don't need to, when you answer these questions, you don't need to refer to, for example, to a measure undertaken by a country. You can also very clearly refer to something done by an organization. Now, what are the questions? The first one is maybe even already the most important. What has been the trend in migration and mobility of health personnel? For example, increasing trend in migration or increasing reliance on international health personnel. So we have heard the stories of Itai, of Gillian, of Martin. I think this would be exactly the question you can report on. What is the situation there in your country, also related or in reference to the trends in international migration? Tell a story. If possible, specify the source and destination countries, at least if possible, provide a source for your information. If possible, provide quantitative data if you have them. But all this, if some of these elements that should be added here are missing, does not prevent you for providing input here. Then the second question is about measures undertaken at country level for health and care workforce sustainability. This is what Itai, for example, has discussed for Zimbabwe. Or this is also something you have, maybe you are an NGO working at a national level that itself is engaged in measures to for health workforce sustainability. These are things to be reported there. And if it's only this story that you have, it's sufficient. Just put your story there and submit this report, and it's welcome. The third element is about pathways of migration. How does health personnel migrate from one country to another? And this could be something where those who have experience on from the perspective of health personnel and their organizations, figures that you can say, for example, one of the pathways is indeed active recruitment, even if you live in a country that has a shortcoming of health personnel and is on the list that has been showed by Agya. This would be a very important information to be shared here and explicitly shared here, even if possible with concrete cases. Maybe you have documents that show active recruitment taking place in your country, etc. The next question is, again, something where health personnel, health workers and their institutions can provide input. What are arrangements for you on the way? What are the working conditions you face related to the domestic staff in the countries where you go, etc.? What is about safety of migration? Are you embarrassed? Are you in any problem just because you are migrating, that your family at home faces problems because you have left your country, or you have a problem in the country where you arrive? This might be a general background of mobility and migration, or this might be specific, for example, the accreditation or whatever. Then two questions about how source countries and destination countries benefited from international migration. I don't know, Agya, if this can also be the place where we can frame how they have not benefited, how they have faced problem because of this. But I think question one is already also the question where you can list problems. But you might quickly say, is this question, how have countries benefited, if this is to be seen literally? You only want to have success stories related to migration. Agya, you can just speak if you want on that one.
No, this is if there is no evidence of any benefit, that can also be stated. And if you actually have evidence that there has been no benefit, that can also be reported. And as you mentioned earlier, it doesn't have to be the entire country. It can be one employer story, one community story. It could be from anyone interested.
Thank you. So maybe Martin also, has Switzerland benefited from migration of health personnel? In a sense, you can say super on the surface, you can say yes. But maybe if you look at the structural impacts and implications in the background, you would rather say no. So this is something maybe where you can maybe give me how would you answer this question? Has Switzerland benefited of the migration?
Yes, directly the health system, because we don't have enough health personnel, of course. But yeah, we have debates around circular migration, if this is well or not, and about as well remittances. Of course, this is a nice thing, but this has always a backside, these remittances as well.
Thank you. And well, it prevents Switzerland from addressing the root causes also of why also people don't work in the health sector.
Yes.
So win-win is to be questioned. And then we have a question on data. I'm not sure if civil society or many civil society organizations have the opportunity to provide data on health personnel to be used to inform policies and plans. But if you are an academic institution, if you have any quantitative data that you can share, this would be the place. And then the last question here, the specific question is on the use of the support and safeguards list that we have seen shared by Agya in her almost last slide. Then we have a question number 9 on general reflections. And I think this is also, together with all what you have reported, this is food also for the expert advisory committee that will review the effectiveness and relevance of the code. So if you look back at those 14 years, what has changed and how could that code have contributed to change in the good or in the bad? And that's it. For the rest, you can have you have a kind of a free bullet where you can put everything you want, and you can also upload documents. So you see, that's not rocket science. So match this reporting instrument with your realities, match it with where you come from, match it with what you would have to say in this field, and then decide if you do it, then just go to that website, go use that link to that online form, maybe prepare it a bit in advance, have the text ready so that once you fill in this online form that you don't need to do a lot of drafting, but you can rather copy paste what you have been done before in the collecting of the information. And stopping here, back to you. Thank you.
Fantastic, Thomas. I think that was a very clear presentation. Thank you for guiding us through that document and through the questions and giving some pointers on where to provide what kind of information. Is there anyone on the panel who would like to add to this now that we have seen Thomas's presentation and the instrument itself, of course? Some additional information that may help the audience in preparing for this reporting or thinking about what kind of information, anything at all? Yes, Agya, please.
So just wanted to clarify, I think in one of the questions, like how has research informed policy? It does not have to be quantitative research on numbers. It could be, implementation research, or it's simply some civil society advocacy on something that led to policy change or that put pressure on the government to do something. When we say evidence, here it does not necessarily have to be, published data, peer-reviewed. Evidence is experience reports. It could be policy documents. It could be internal organization documents that based on certain rationale or certain evidence, personal evidence, something took place. So just wanted to highlight that it does not have to be quantitative only. It could be qualitative also. It could be just policy documents also.
Fantastic. Yeah, I think that's a very good addition. Perhaps some might be sort of, doubting whether the evidence that they possess would be suitable. But hearing you, there is a lot that actually will help you at WHO headquarters assess a bit how the code is implemented and what the experiences are. Thank you so much. Yeah. Do I see other hands? I don't think I do.
Have you invited participants to raise their hands?
I will now go to the participants. I invited the panelists to give additions, but I will. Okay. No, that's okay, Thomas. We know each other for a long time. I would like to go to the audience for questions if there are any, and please let's keep the questions also technical, in the sense that, do you have questions on the reporting instruments? And let's not dwell on the political side of this whole debate, because then we will be here forever, and we don't want to be. But if there are any questions, please raise your hand and Pearl will unmute you. I have no idea how people who raise their hands can be seen. I'm sort of counting on Pearl here.
There are no hands yet.
No hands yet.
Yeah, it was all too obvious, you know.
Then, if I may, and I don't know if Gillian is still here, I remember when I had my preparatory talk with Gillian, that she also said to me that they from PS Link also played an important role in convincing the Filipino government to engage in the reporting process. And this is actually an important point to make here as well. As a civil society organization or a non-state actor, you can also reach out to your government to well, encourage them, stimulate them, motivate them to use the reporting instrument, because you have seen in Agya's presentation that the response rate from member state governments is sort of stable, where it should be growing. So if at some point you have good contacts in the government, you could just, you know, point out to them, the reporting instrument is there, you should be reporting, please do so, and let me help you if you need help. So an important point to make, I think. I see one thing for, yeah, it's Felix Lichawa for Agya. Mm-hmm. Can you outline a little bit how you will process the information, stories, evidence eventually? Will you report back to the countries, especially on the critical points too? Very interesting question. Agya, please.
So all the reports that we receive in each round of reporting, they will be summarized and it will be presented to the World Health Assembly. Additionally, since this year is also the year of the review of the code, this will also be presented to the expert advisory group who are reviewing the code itself. And this will be one among the several pieces of evidence that they will review. And based on all of their review, they will then provide recommendations, and that could include to the Secretariat, to us, to countries, to the World Health Assembly. It depends on the findings and the advice of the advisory group on how this is processed. But the idea is to help countries move towards the objectives of the code.
A very important addition, I think. Yeah, thanks for this clarification. So actually this time round, this fifth round of reporting serves a dual purpose, not just to comply with the reporting process in the code as an instrument, as a governance instrument, but also to feed into the expert advisory group who will carry out the independent review of the code's effectiveness and relevance. So all the more reason, I think, for people here in the room today to pick up that that challenge and start engaging with the code reporting.
And just to clarify, it's not just the review of the effectiveness and relevance. There's also a text that says, you know, this is a dynamic text. It can be updated if required. So far, the past advisory groups have not felt the need to do that. We cannot say the same for the future groups. So it may be more than relevance and effectiveness, or it may be limited to that because it's a new group. We don't know what they're going to say. It all depends on the kind of evidence that we receive.
But that's also actually very interesting addition, because hypothetically speaking, if anything comes up in the independent stakeholder reports, or in the national reporting instruments for that matter, which is sort of new or an extra element that we would like the expert advisory group to look at. They might take up that additional point and also move towards a more, well, revision of the text or something. Nice, nice. Thank you for this. Yes, and there is another question in the Q&A by Aysel Rahimli. Nice to see you here, Aysel. And our question is, are the recruitment agencies encouraged to submit these reports as well? Or is there a separate report for this group of stakeholders?
Okay, it's better if I say this in orally. There is a separate reporting instrument for recruiters where we ask about their practices, like how do they practice, how many recruitments have they undertaken, what are the top countries they work in. However, they are also free to report also through the independent stakeholder instrument if they feel that they can contribute through that instrument also, because the objective of the two instruments are different.
Interesting. Okay, so there is a separate reporting instrument for the recruiting agencies,
yes,
but they could also engage with the independent stakeholder reporting instrument, I guess, because they are, yeah, because they have different goals. Yeah, interesting. Thank you. Thank you. If there are no more questions, then I suppose that everything has been crystal clear, which is fantastic. And really thanks to all the speakers here. I would like to pass the floor to Geneviève, because this particular webinar today has been prepared by 3 organizations. That's MMI, you've heard Thomas, by Wemos, that's me on screen, but Pearl very much behind the scenes doing the technical stuff, and Public Services International, PSI, represented here today by Geneviève. And she will sort of wave us off with some extra information. But for now, from my side already, thank you. Geneviève, you have the floor for the last words. Thank you.
Thank you very much, Corinne, and to all our wonderful speakers today. And I'm very, very encouraged to see many PSI affiliated trade unions representing health and care workers also attending this webinar. And I hope that was very helpful for us to understand the big opportunity for us to be able to participate and bring evidence to the WHO Secretariat in order to strengthen the implementation of the code. This is just to say thank you, but also to segue us on an event that we are also organizing on the sidelines of the 77th World Health Assembly here in Geneva, which is, I think Thomas has it on his background, towards a global code of practice that promotes the rights of the health and care workforce. So this will be more of a political discussion, but based on testimonies of health and care workers, on what the challenges and realities are, and how we can make this code a win-win-win, and what are also the positives and the negatives. So this is only an in-person event in Geneva, which we're going to hold on the 30th of May from 8 to 9:30 a.m. So this is a breakfast meeting at the Hotel Warwick in the Geneva, Cornavon, the train station area. So we invite you to join us for this, and there's a pre-registration. There's also the link, and we really hope that you can join the conversation. Again, thanks so much on behalf of PSI and my co-organizers, MMI and Wemos. Thank you for participating, and we really hope to have a very good round of reporting for this time. Thank you.
Thank you. Goodbye.
Thank you. Thank you all. Bye-bye.